for theme for this meeting. Oh, let me get rid of that. Of adolescents in the ED. Let me just get rid of that. So basically, I thought we've had quite a lot of stuff on respiratory surge and babies, but I think certainly during COVID, what I experienced was sort of seeing a lot of adolescent issues, including mental health, and especially with Freedom Day gone, 2021 being the summer of love, and the pubs back open. I think it might it was good to go over sort of issues to do with teenagers and adolescents, because you may be seeing some of this stuff in your ED. So there you go. So basically, in terms of what I'm going to talk about is that I've got a case discussion, which was a patient I saw last year, and it's got I personally think it's someone who I saw and looked after, and it's a very interesting case, and it's got really good sort of a lot of good learning points that I learned from that I wanted to share with you guys. And then we'll probably have a little mini break depending how long the case discussion goes on for. And then I'm going to talk about the approach to the intoxicated child, mainly focusing on adolescents. So first is case discussion. So I've called it Smoke and Mirrors, and hopefully you'll see why. So you're in the ED. So it was a night shift. I was in the ED. To sort of give it in the context, so this is about my third night. So it's in Leicester. So Leicester's quite a busy PTD, even with even lockdown. We're still seeing about 100 patients a day just in the PTD. So we have a consultant up until 1 o'clock in the morning. So the consultant had just left, and one of the SHOs came up to me and said, "Can I discuss a case with you?" So the case was, so she wanted to, it was a 15-year-old girl who basically was brought in by ambulance, but she managed to walk into the department. She basically was complaining of left-sided weakness and numbness, and had an episode of right-sided facial droop 2 days previously. It was associated with a mild headache. She was feeling a bit increasingly tired, and the SHO told me she has a completely normal neurological examination. And the reason why there's a picture of Gemma Collins is this is what the patient looked like, about maybe a couple of stone lighter. So try and think of your head, try and picture what this patient would look like, and the sort of attitude I was getting when I went to go and see him. So she basically says to me, "I don't know what to do." So I go and see this patient, and I see her with her mother. So she's very uncooperative, and not very. And when I say uncooperative, she's not very engaged with the history taking and the examination. So there's no fever, there's no history of trauma, there's no visual disturbance or speech disturbance, no signs of meningism, and she's normally fit and well. Examining wise, so I observed her using her left arm, though the left arm was subjectively a bit weaker, but I observed her sort of holding pens, holding a phone. She was able to wake but needed some assistance. She had normal cranial nerves and no cerebellar signs. It was very difficult to assess sensation and power. She possibly might have had a bit of pronated drift, and the reason why I say possibly is when I got her to, I'm not sure if you guys can see me, let me just see if I can. When you get her to raise her arms up, she's managed to raise her arm out, but then her left arm sort of instantly dramatically flops down. She also, when you ask her about where her numbness is, she basically with one finger just points to one bit of her arm and says it's there. So very non-specific. So she has no subjective dermatomal sensory loss. So what other things would you want to ask her? Or is there anything else you wanted to, or any other sort of tool that might be useful to get a bit more of a history from her? So one of the things that's quite helpful, this is a bit of lightning learning, but I'm sure people have heard about this, about the heads assessment. So it's a good tool to sort of ask about things that other things that are going on, and essentially, you know, if you don't ask someone, you're not going to get an answer. You're not going to find out. So headless stands for home. So who lives at home? What relationships lie? E stands for education. So what's going at school? Stresses. How's she getting on? Friendship groups. Are there any signs of bullying? E stands for eating. So is she got any concerns about her body shape or weight? Eating habits. A is activity. So if she's meeting with friends, any hobbies, how much time she's spending on internet, TV, social media. D is for drugs. So, you know, smoking, alcohol, and other recreational drugs. S is for sexuality. So is she in a current relationship? She's sexually active. Suicide. She feels stress. Previous signs of thoughts of depression, suicidal ideation, deliberate self-harm, and awareness of sort of risk-taking behaviour or safety. So like, is there violence at home, violence at school? And it sort of gives you a good idea of, about what other things are going on. So I got her mum to come out of the room, and I basically asked her all these questions. So she tells me school's going well. She's got supportive friends and family. She has a boyfriend. She doesn't have any relationships issues, but she admits being depressed due to sort of the COVID lockdown situation, and she's had some suicidal ideation. Mother's not sure what's going on, but doesn't really believe what her symptoms are, because been resolving and then coming back again. But she also mentions that she's concerned that about nitric oxide use and binge drinking, and they're her observations. So all within sort of normal Pew score. So what's the plan? So first thing that came to my mind is nitric oxide use, so or NOS. So nitric oxide, so it's a commonly used and quite easy to obtain drug. Highest use in the world is actually in the UK, and it's dubbed like a legal high. And what happens is, essentially one hit is, you get these canisters and you fill a balloon up with them, and then someone inhales the balloon and you get euphoria. So nitric oxide was developed in 1975 when someone mixed nitric acid with iron shavings, and basically what nitric features, what happens when you get hit is that you get a moment of euphoria, you get some visual hallucinations, but you also side effects wise can get episodes of fainting, nausea, dizziness, and often people can injure themselves. And basically what nitric oxide does is inactivates B12. So it oxidizes cobalt and the B12, inactivating it, and then methylonium synthase is irreversibly blocked, which basically it's needed for DNA synthesis and myelin production. So you basically get symptoms of pernicious anemia, so bone marrow suppression, reduced myelin production, and polyneuropathy. Most common side effect people might see in the ED is neuropathy, so mainly symptom motor neuropathy, so mainly affecting the lateral posterior cord, so that's your vibration, proprioception, fine touch, and you can get some ataxia from it. And essentially, on bloods wise, you'll get a macrocytic anemia, and also you might see other evidence of bone marrow suppression, so low white cell count, low platelets. So the treatment for it is to stop inhaling nitrous oxide, and then B12 supplements. So I thought, great, you know, when she told me that, I thought, oh, this is, you know, this is this might be something worth exploring. So my differentials at the time were, is this a functional disorder? Mainly because a lot of her neurology and her complaints didn't particularly make sense to me. But I think it's important to sort of rule out organic disorder. So less things I learned over the years sort of practicing emergency medicine is when patients present sort of first presentation of something that's very vague and doesn't particularly make sense, it's always important to try and rule out a metabolic problem. So things like electrolyte disturbances, renal problems, because they often present with very vague symptoms, rheumatological problems, for example, and rule out neuropathy. Let's see, so let me go back. So I basically gave her, so with people presenting with functional symptoms, I often give them a long speech saying, I think it's quite important if you think something's functional, to say to the patient that it's important not to say to the patient that your symptoms aren't real. I think acknowledging their symptoms, what they're experiencing is real to them, but explaining there's no underlying cause for it. So the way I often describe it is, I use blushing as a example. So blushing is a manifestation of you feeling embarrassed. There's absolutely no reason why you should get flushed cheeks when you feel embarrassed. But it's a physical manifestation of how you're feeling inside, and that's how I use it to explain sort of functional disorders. So I gave this long speech saying, I think it's important to rule out that the nitric oxide that you've been taking hasn't done any damage, but it might be because you're feeling quite low and depressed, it might be that your symptoms are a manifestation of that, and actually maybe getting you some mental health. Mental health help would, or seeing somebody getting into sort of like the community services might be helpful, which you'll see what happens later. So I do an ECG. Her blood tests that we've done, she essentially, her U's and E's and were completely normal. So, and CRP and no electrolyte disturbance. But she had an HB of 69 with a low MCV and normal platelets and reticulocyte count. So essentially a microcystic anemia, which is not really fitting in with B12 deficiency. So based on this, I went back and took more of a history. So with anemia clear cause, and she basically said that she gets been getting very heavy periods most months, where she changes pads quite frequently, but there's no other bleeding or relevant family history. So how would you manage this? So opening up to the floor. See if I can get the chat up.
Admit and do a full iron profile with a gynecology input.
Yeah. So would you be sending her home? Would be, or how would you normally manage menorrhagia in the emergency department?
I would not send her home. I would, I mean, I would want to find out whether she's actively bleeding currently or not, and then take it from there. Yeah. And the other one is, you wouldn't send anybody with a hemoglobin of 69 home if they were an adult. So why would you send this girl home?
Yeah. Anyone else?
Yeah. So Dan, is there any sort of setting aside sort of the presenting complaint, is there any signs of sort of decompensation because of her anemia?
No, well, so she's feeling tired and she's got weakness. So I So my impression is that I would say she was symptomatic from this. So which will explain what my management plan was but my point is, a lot of people, you can potentially, some people may try and treat this conservatively, so with iron supplements, tranexamic acid for the bleeding, and then considering starting on NSAIDs or something like northisterone. I think with anemia of an HB of 69, from my point of view, that would be quite brave. So what I did was I spoke to the on-call gynecologist. Now, as this hospital was out of region, so this is when I was in Leicester, the gynecology department, let's just say, were less than helpful. So basically said to me that they feel that this weakness in the HB didn't explain what was going on, and that actually she could just be followed up as an outpatient. I'm sorry, Ed, I saw you raise a hand.
So yeah, I was just going to say that sometimes it can be a little bit over focused on the number, so like the HB of 69, and it depends very much on how long they've been anemic for as to how symptomatic they're likely to be.
Yeah.
So I think that the clinical effect is always going to be more important for the decision making than the actual number. I've certainly seen patients with much lower hemoglobins who have compensated really well because it has been a very chronic anemia, and patients with a higher hemoglobin who are much more symptomatic because it's developed more rapidly.
Yeah.
The physiological compensation mechanisms can be, especially in children, can be really very impressive. I think the complicating factor here, because we sort of can't consider the hemoglobin as a point mass in a vacuum, is that there's quite a lot else going on with this girl.
Yeah.
And so it's not just about the hemoglobin and the clinical effect on that. There's quite a lot of chaos factor here, which would make me concerned that there are variables which will change and overlay the anemia. That's my biggest concern.
Yeah, so I'm really glad you brought that up, actually, because my experience of treating menorrhagia in the emergency response, exactly what you're saying, is actually kind of depends on the clinical context. So I have seen people sent home with northisterone on lower HB levels, probably maybe not quite as symptomatic, with gynae follow-up. So my concern was the same as yours, is that I wanted gynae to come and review in the department and say categorically this is not a gynecological problem, because I didn't necessarily want to get her referred to pediatrics, because their thing, well, she's got heavy menstrual bleeding and low HB, that could explain the symptoms. So I think as we'll go on to see later, listening to your gut, and if something doesn't feel right, or my impression at the time with her is that I can't send this girl home because she's got some symptoms. So the weakness I can't overly explain with an HB level, and I think actually raising hemoglobin with that weakness suddenly gets a lot better and the tiredness gets better. That's it. But actually, is there something else going on? And certainly when I was reflecting about this, one of the things that my consultant said to me was that actually you could easily send this girl home if. So I had a big Barney with the gynae department, who basically said, I'm not going to see this person in the department. And I said, well, I basically said, so you're saying to me I can discharge this patient on your advice over the phone. So eventually she got admitted up to gynae, and she was admitted to the ward, and I thought she'll probably maybe have a blood transfusion, and we'll go from there. So next day, so daytime review, she basically ended up on a peds ward, and during the day the nurses got a bit more concerned about her and actually asked one of the pediatric doctors to go and see her. So during the daytime she developed worsening slur speech and dysphagia with some facial numbness, and she had an unsteady gait. Examining her, the pediatric team found she had a positive Romberg's test, increasing spasticity on the left hand side, and Babinski positive on Babinski reflex positive on the left. She underwent an urgent MRI, which showed she had a right MCA infront and small carotids, and then went on under the stroke team to have a CT angiogram, which showed aortic and subclavian chronic wall thickening, consistent with a new diagnosis of Takasu arteritis. So pretty left field. So stroke in children. So there's roughly about 400 cases a year in the UK of stroke in children. Mortality rate can range between 5 to 10%, but over 50% of patients can have long-term neurological impairment, and that's a lot of that might be to do that a lot of these patients or symptoms of diagnosis is missed. There's normally an underlying cause for stroke. So it's a lot of the time in children it's associated with congenital heart disease and sickle cell anemia and drug use. And there's between a 10 and 20% recurrence rate. Now, I think the most common type is ischemic type stroke, though, in proportion compared to adults. So roughly in adults, 85% is ischemic and 15% are hemorrhagic stroke. That ratio is a little bit more 1-to-1. So there's a lot higher proportion of children will have hemorrhagic strokes compared to adults. This is a guideline taken from the Royal Children's Hospital, Melbourne. There's sort of quite variability about how stroke is managed, or guidelines wise, but I usually go with the Royal Children's because they basically got a good set of guidelines. So essentially managing these patients is an ACE approach. Oxygen if they're hypoxic. Consider treating any hypertension, treating any seizure activity, and avoiding hypothermia. So focal limb and facial weakness, visual disturbance, limb coordination, ataxia are more likely to indicate an arterial stroke, whilst headache, altered mental state, vomiting, and signs of intracranial pressure, so meningism, is more likely to be a hemorrhagic stroke. Now, she had a kind of mix of both of these. But once you suspect the diagnosis, it's important to get some sort of imaging. So here they talk about MRI or MRA, and if not possible in under 30 minutes, then going for a CT or CT angio. I think what's important, certainly in this context, if you're suspecting a child has stroke, is getting a stroke team involved quite quickly, because often these are difficult diagnoses to make, and obviously they have quite some of the treatment options have quite big implications. So certainly I've had some bad experiences of giving TPA to people. The indications would be that, it's a confirmed arterial stroke. If someone's aged between 2 and 17 and there's a pediatric and national stroke score, so pediatric NIH stroke score. If it's between 4 and 24, so i.e. they've got so few symptoms that it's not particularly noticeable, or they're so severe. The extreme end, it's not, I think the evidence to giving thrombolysis and getting the resolution of symptoms versus the likely complications would more be not giving it, whilst if they have a stroke score between 4 and 24, then it might be worth doing it, and within a time frame of 4.5 hours. Obviously, there's other interventions, so like endovascular, so clot retrieval, and sort of conservative warfarin therapy. And then afterwards, once you've treated the initial stroke symptoms, the main focus will go on to secondary prevention. So that may involve anticoagulation and then investigating about the underlying cause. So Takasu arteritis. Now, what is it? Now, it's an extremely rare large vessel vasculitis. So it's sometimes known as aortic arch syndrome. It's very rare outside of Japan. So it was originally described by Mikitutu's Takasu in 1908. And basically the vasculitis causes thrombosis and stenosis of large vessels. So when she had a more full CT, so she had involvement of the aortic arch, both carotids, both subclavian arteries. Girls are more affected than boys, so 90% girl incidence, and mainly most people present between the 20 and 40, but you can be as long as 5 where you get symptoms. So it comes in stages. So stage 1, common symptoms, you get night sweats, neck pain, mild chest discomfort, joint pain, hypertension, limb claudication, and then stage 2, you get more persistent circulatory symptoms, and then stage 3, you'll get complications. So in this case, stroke. It's important. So if you look back, if I go back to her observations, now I'm not sure. So she had a blood pressure of 120/41, which sort of speaking to my EM guys who see adults, you might look at that and not think, oh, that's particularly high. It's very important in children that when you think if you're looking for signs of hypertension, that you plot their blood pressure against their height, because it does vary of age, and a normal blood pressure in an adult might not be a normal blood pressure in a child. So I don't remember calculating whether she was hypertensive. I don't think even with a blood pressure on 20/41, she was particularly hypertensive. She was quite tall, but it's something that I've learned from sort of during my PEDS year. And then other complications, you could get myocarditis and heart attacks, so MIs. So my learning points from this were, so adolescents are very challenging, and certainly so I think certainly a phrase I learned during my time in pediatrics is never trust a neonate. I would apply that to adolescents, so never trust an adolescent. Usually if they present to the emergency department, they should be in like their peak physical condition, so it's quite rare for them to come in with medical problems. So being inquisitive and try and think at the back of my mind, is there something what else is going on? And reflecting on this, I think there was a lot of human factors that sort of affected my decision making. So one of them was her attitude, and that's why I was saying in the first picture that try and get this picture of this child in your of what she looked like, or what I was confronted with in your mind. Someone who's not very interested, she's not engaging, it's late at night, I'm the only senior in the department, I've got other things going on, this person's going to take lots of time. But it's sometimes important actually to take some of that time to try and figure out what else is going on. Now the other question is, people might say, argue, is the question of imaging her head at the time. Now she did have pretty subtle signs at the time when I saw her, looking back, which I partly ignored, because one reason was because she was very uncooperative with the examination and very vague. The other thing is that at the same time, so as I came out, the patient I'd seen before was another patient who was very similar aged. He basically came in with very similar complaints. So he was coming in with frequent fainting, weakness. He had his head, and then basically I'd seen him every single night that week, and I'd seen him the week before. He had very similar neurology, and I actually CT'd his head and it was negative. And he's actually gone on to have he's got a very complex family background where I tried to call his mum once, and she basically hung up the phone on me to give you some sort of context of what his home life was like. And his case influenced my decision on getting neuroimaging. Also, so being inquisitive, so using the HEADS framework to find out what else is going on. But also remember, neurological patients' presentations aren't binary. You know, patients don't read medical textbooks, so often they might, their symptoms might not make sense. But certainly taking time and using time to maybe observe and see things get worse, because symptoms may evolve. And lastly, like we were saying with Ed, is that actually listen to your gut. So one of the feedbacks I got from one of my consultants is actually you did well to admit her, because you could have easily sent her home. And the reason why I didn't send her home is that it didn't feel right, and I felt that was something else going on, and that I don't think I could have sent her home. The fact she was still needing help to try and get around with her mum at the time, and ruling out an underlying organic cause. So I hope that was all right. I see Ed's raised your hand, and there's other things in the chat, so I'm just going to see if I can come out of it and see if there's any questions. Any questions at all?
Sorry, out of interest, did she get transfused in the end?
So say that again?
Did she get transfused in the end?
She didn't actually. Oh no, she did. She did get transfused, and she was started on high dose steroids. So basically, anemia is caused by, it was anemia of a chronic disease, which you'd get microcystic anemia. And Takasu's arteritis is basically treated with high dose steroids, so prednisolone, and then blood pressure controls to reduce risk. The key with it is to control her blood pressure, which you'd need to get rheumatology and renal advice from. Often the drugs that we use in adults for hypertension are different to children. So certainly when I was on PIC, I was using a lot more hydralazine and sodium naproxide that I had ever used compared to adults, for example. So I can't see who's raised their hands. So let's have a look.
So I was just going to say that there'll be a lot of people sort of watching this, sort of anxious about missing pediatric stroke, because there's a huge focus on it at the moment. And if you're anything like me, you're wondering, well, what's the formula? And I was just going to say, it reminds me very much of the sort of the drive over the last 20 years to get better at treating sepsis and improving sepsis outcomes.
Yeah.
You know, they decided that was a thing 20 years ago. That's gathered momentum in the last 10 years. You need three things to improve outcomes. You need awareness, you need better treatment protocols, and you need a clear formula for diagnosis. And a little bit like with sepsis, I suspect that what we'll achieve with pediatric stroke is that we'll get everybody thinking about it more. We'll be a little bit clearer about how to treat it effectively. But 20 years from now, we still won't have a really clear way of telling people this is how you recognize it. A little bit like with sepsis, it will remain an art, not a formula. And it really is. It's subtle and it's confusing. And your case is excellent, because there was elements of diagnostic overshadowing, and the bit where nobody wants to take ownership for it is classic, because vague presentations lend themselves to, well, it could be three different kind of problems. So we want three, so the, neurologists are saying it's neurosurgical are saying no, it's adolescent psychiatry. They're saying it's gynecology. Everybody wants it to be somebody else's problem.
Yeah. Nick, you had your hand up?
Yeah, thanks ever so much for that, Dan. That was a great case. I have the joy of working with Edward 2 days a week in the emergency department of North Norwich, and then working in paediatric neurology for the rest of my week. And these are absolutely the kids that we're all terrified of missing, right? But they are incredibly rare. And I think that's a great catch in ED. I guess for me, with the power of the retrospectoscope, looking at your presentation, as soon as you'd mentioned that she might have a bit of a pronator drift, that for me is, from the neurology side, is a sign of a really good neurological examination in the emergency department. But really, that's one of those things that's very subtle, but that really is quite sensitive for pathology. If that's a reproducible sign when you examine a young person, that for me is a big red flag. And you're right. I think it's a big call to say I'm going to CT her head at 1 o'clock in the morning. but pick up the phone and have a chat with people. For the East of England, our regional stroke service for most hospitals is Cambridge, and the neurologists at Cambridge are very happy to be woken up for a phone call about a suspected stroke, particularly if you're correct. Maybe not for everything, but if someone's got sort of, none of us are 1 o'clock in the morning are perfect at a neurological examination. But if you think you can reproduce a sign, then I'd take that really, really quite seriously.
I think that's an excellent book. So I did a stroke job, so that's why I do pronator drifts, and I've actually caught a lot of strokes using it. And I think one of the reasons why I was kicking myself a lot about this case is that I thought she might have had one, and I didn't listen to my gut, because this is what I was saying about being influenced by. I was completely influenced by that other patient. When I did CT him, and he basically, it was negative, and he walked out of the department 2 hours later. And I thought, I'm having a run of these, it's exactly the same. And I think that's why this is what I quite find this case quite interesting, and I did a lot of reflection on it. But yeah, I would completely agree with you, Nick. I find pronator drift is a really good sign of something neurologically going on, and actually I've CT'd a lot of people on the basis of that, and that might be the only sign I managed to pick up. So AJ, you had a question?
Just to follow up, Dan, I just wanted to know exactly that, whether the patient had a CT prior to an MRI, or were they that convinced that they went straight for an MRI?
They went to straight. I'm
just trying to identify.
It was an MRI. She went straight for. So the other argument, I think the other thing to say is that, probably reflecting on it, she was probably having TIAs, and whether she had a TIA when I saw her, and then she went to the ward and then had a full-blown stroke, that's debatable. So whether if I did CT her, that came back negative, and then
you would have sent her home.
I would have had even more of a reason to send her home.
That's exactly what I was trying to get at. Would there have been any sort of benefit, because you had a gut instinct, you kept her in? If you had done a CT scan and it was negative, you would have sent her home, and then she would have come back a couple of days later with a full-blown stroke, isn't it?
Well, I think this is the point where I was saying neurological presentations are not binary, and actually, if it was a TIA, then she needed an MRI. Now, am I going to get an MRI at 1 o'clock in the morning? Probably not. It's worth keeping her in, getting reviewed in the morning. The neurology disappears. That's great, and and her symptoms suddenly get a lot better. But if they didn't, then she could go on to having imaging, and obviously if she can get worse, then you still got the option of doing a CT scan.
Dan, can I chip in there? There is a halfway house there, which is, if we follow the stroke guidelines in children to the letter, our stroke colleagues like a CTA with that initial CT, and you would have spotted her pathology on that. So it's one of those things where we very often don't follow the guidelines to the letter, because radiology don't like doing them. It's a bit of extra time, it's a bit of extra radiation, it's an extra sequence. And so we go, okay, well, we're not quite sure, so we'll just do the CT. But if you're doing it because you think they've got pathology, then adding in that CTA will stop you missing those cases. Well, will greatly reduce the number that you potentially miss.
That's great. Thanks for your input, Nick. That's really helpful to know, actually. I thought, because we, so when I did the stroke job for the TIAs, we had this TIA protocol MRI. So basically, you would fit all these MRI heads in between the normal MRIs, where they would kind of do larger slices, so the scans were a bit quicker. But you often picked them up on that. So actually knowing that a CTA is actually quite sensitive as well is quite helpful to know. And finally, Sarah, the other question.
Well, you've sort of answered it actually, Dan. It was just about what the cause of her anemia was, and whether, because that I think was the focus of what you'd found when you saw her in A&E in terms of anything abnormal and the reason sort of for admitting her, but whether that was just a red herring. But you're saying that was related to the arteritis. Yeah,
well, I mean, so reflecting back, actually, so, her tiredness, her depression, her menorrhagia were probably all caused by this vasculitis. So they all are signs of vasculitis, and actually she had a unified diagnosis. it was just very difficult to pick it all out because there was a lot going on. There was a lot of red herrings, so like the nitrous oxide. You know, she was saying to me, "Oh no, I don't do it that often." But her mum was very much like, "Oh, she does it all the time. I'm concerned about her use of it." And that was actually the main reason I did blood tests. So actually, I was fully expecting a blood test to come back completely normal, and my plan originally in my head was potentially sending her home. And actually, when things started coming back abnormal, then that's where we ended up where we were. But anyway, thanks very much, guys, for your inputs. Probably what I would suggest is if we have like a 5-minute break, or like just to people to get some. Well, if we start at 25 past, if we just get if people want to stand up, walk around, and then we'll get started. This presentation